this is Dr. Hansa Bhargava. I am Chief Medical Officer of Medscape Education. I'm very excited today about this panel discussion about the era of remote monitoring and, of course, the impact of wearables on healthcare. Thank you so much to our esteemed panel for being here. And let's get started, guys. So I just wanted to go around the room and let everyone give a short introduction about themselves. Jhonatan, let's start with you.
Thank you so much, Hansa. Hi, everyone. My name is Jhonatan. I'm a medical doctor. I'm the Chief Executive Officer of Lapsi Health, and I also founded JBD Healthcare. I've been involved in medical technology and the implementation of medical tech for many years already. I don't want to talk about my age. Yes, I have also been involved with different hospitals and organizations in how do we actually place healthcare in a more medical, strategical way. And I'm very happy to be in this panel together with all of you guys.
Wonderful. Well, thank you so much for being here, Jhonatan. Sandeep, you're next.
Thanks, Hansa. Nice to see everyone again. I'm Sandeep. I'm one of the medical directors here at Biofourmis. Biofourmis is a company that helps deliver and empower personalized predictive care anywhere. And currently, that's our model in terms of delivering virtual access to care and actually managing patients using data from the patients, as well as connecting clinicians into the care model. I spent the last 10 years building virtual care delivery programs. Actually started several companies in that time, collecting data, managing CHF readmissions, as well as AI tools for clinical decision support at the point of care, and then most recently, large-scale virtual delivery models. So Biofourmis has been a unique opportunity to combine all that in one place. So looking excited to share what we're doing and learn what you are all up to. Thank you.
Wonderful. Well, thank you so much for being here, Sandeep. Ami, so nice to see you. Hope you're doing well. Can you tell us a little, I know you, but if you could tell the audience about yourself.
Absolutely. Thank you for having me, Dr. Bhargava. So this is a great panel to be with. My name's Dr. Ami Bhatt. I'm a cardiologist. I'm at the American College of Cardiology. We are a 56,000 member organization, the largest global organization for cardiologists, and I am the Chief Innovation Officer. So we really focus on the digital transformation of healthcare delivery. I've been practicing telemedicine myself since 2013. Soon I'm going to be able to say 10 years. Really in cardiology, our focus on remote monitoring has been around for a long time, but it needs to morph now. It needs to change because the amount of data that's coming in is coming in at a pace that individuals find challenging, and we can probably do better. And so really one of the focuses is how do we help clinicians and patients by taking all of this remote monitoring, make it work better, and then really learn more from it because it's such an opportunity. So excited to talk about that with everyone today.
Wonderful. Well, thank you for being here, Ami. And Ian, please let us know about yourself.
Thanks. It's a pleasure to be here. So yeah, my name is Ian. I'm a Global Business Development Manager at Ascom with our Strategic Health Partnerships team. So focusing on clinical data management, medical device integration, that sort of thing. I'm, as you can see, the only non-medical doctor here, but I have about 15 years experience, I think, working in clinical software, workflow change management, and that's why I'm really excited to join this panel.
Wonderful. Well, thank you so much to all of you. And I'll just give you a short overview of myself. I am Chief Medical Officer of Medscape Education. Our vision is to actually educate clinicians. We have over 780,000 clinicians that we speak to in the United States, 3 million around the world. And we're particularly interested in the digital space right now, knowing that clinicians are a very big part of the workstream solution. So I will be asking you all about that at some point, but let's just get started right now and ask each of you, in your opinion, how do wearables stand to make an impact in healthcare? So I know that's a general question. We'll get more specific soon, but I will ask Ami that first, and then we'll go around the room.
Sorry. When we think about what we're doing to monitor our patients, we're right now really doing episodic care still, right? So we see a patient once a year and they have a disease 24/7, 365. So the fact that we're only seeing them twice a year and then making decisions, now that we look back at it, doesn't seem to make as much sense anymore. So the idea to have some version of continuous monitoring for patients, or even episodic, but at the right times when people are feeling things, when they're doing or trying something new, right? And choosing those times, I think that's really quite important. And so with that in mind, I would say the concept of remote monitoring, whether that is, clinically prescribed devices or whether we're talking about wearables, I think it's a really important part of how we start to engage the patient more in self-advocacy and empowering them, but also how we get to the point where we're doing continuous care, which at the end of the day will allow us to get to patients earlier and be able to then make those moves that we need to make, whether that's medication, whether that's lifestyle, or whether that's intervention, in a way that it is optimally timed. Because if we look at the cost to patients of their health and we look to the cost of the system, it's oftentimes when things are not optimally timed that everything goes wrong. And so I think really continuous care is essential. And that's why remote monitoring, including wearables, is something that we need to embrace.
Sandeep, can you tell us a little bit about the continuity of care that Ami is talking about, and how these amazing technologies can actually help us with that?
Yeah, absolutely. In terms of Ami's, what she just described is absolutely right. Right. When we were helping monitor CHO patients 10 years ago, we were relying on episodic weight data, right? Once a day weight checks, and hoping that we were able to catch early prediction of progression where we were helping to stop a readmission. Fast forward 10 years, using the right set of data and digital biomarkers in a continuous fashion allows us to now move from actually hoping to stop something after it's happened to actually prevent something before it happens, right? So that's really how continuous data for us is helping inform our FDA cleared analytics to help understand in a predictable way how you can actually manage patients before they start to deteriorate. I think that's been a big shift that's happened over the last 10 years, going from that episodic period, even from collection of data, not just managing patients more frequently, but just having the insights now. So that's really what we leverage, is that wearables collecting the appropriate data in a continuous fashion, and then our tools helping manage those patients at scale. So you're not reliant on a large resources in terms of managing all that information flowing into our care decision-making process.
Yeah, no, absolutely. I'm going to play a little bit of devil's advocate here, in terms of collecting the data with biomarkers and wearables and all of that is fine and good, but how do we ensure that we're getting a diverse picture of that data? Because we know, like, I can just talk about pediatrics. I am a pediatrician, and we compare children when we take their weights and heights to growth charts that are probably decades old, and frankly, based on a lot of the Caucasian population, so not necessarily the best comparison. So similarly for wearable data, diversity in the populations should matter. So let me ask you that, Ian. What do you think about that question?
So yeah, that's a really interesting point. And as you say, a lot of technology is built on the average person, which tends to be an adult male who's Caucasian, right? So we are seeing definitely an increase in the tech market, where technology is being built with the right kind of people in mind to measure diversity properly. So we're seeing pulse oximeters that work better on darker skin than we used to see before. But we do need to see, we need to collect the information and marshal it in the right way, right? It's not just about taking information from the patient and then presenting it somewhere else and then saying, okay, make some decisions on this. We have to marshal the information. You have to provide some decision support that goes behind that. So we are seeing also an increase, I suppose, in asking for a pass-through from the data to a larger data analytics tool. So right. Artificial intelligence, this kind of thing, machine learning, which can really start to make sense of the large volumes of data that we're looking at. Because when we're monitoring patients outside of hospital, we're talking significantly larger numbers than just the hospital beds, right? So we need to make more sense of that information. So passing through to high volume data analytics is going to be a big step forwards.
Yeah, absolutely. Jhonatan, your thoughts on this, or even like the impact of this data on continuity of care, as Ami brought up?
Well, I'm regarding the question that you just asked Ian about diversity, I think it's a really interesting question, because until now we don't really have that data for all these other ethnical and gender groups that are so important if we want to be really diverse and we want to create this healthcare to be more accessible, right? So That would also give us a lot of knowledge and information that can be placed into clinical trials, and where we can actually develop medication in a way better way, with more democratization. So I think in general, when we talk about continuous monitoring, and when we really, cross that boundary from just doing intermittent gathering of information, whether it is vital signs or ECG or EEG, and we go to the next step, which is gathering it continuously, where it becomes then, as Sandeep said before, digital biomarkers that we can use then to trend and to understand disease, to understand efficiency of medication, to understand worsening of a specific chronic disease. We're actually creating a system in which we can collect all this data and then make medicine a little bit more democratized. By as we said before, by giving it or making it more accessible to people from different ethnical groups and genders, etc. So I think that the first step in our case, when we talk about diversity, is trying to make sure that not only one group of the population gets to be remote monitored, but actually as many as possible. And I think there is a regulatory limitation there. And there's, of course, a reimbursement limitation that also we have to transcend to make that happen.
Yeah, absolutely. Ami, please.
Yeah, can I add two things? So I think this is the exact right train of how we need to go about this in the future. But I guess two specific things. One is we're going to, in the beginning, need to go into specific communities and actually demonstrate that this works in communities that may not trust us, data, what's happening. There's a black box, and all of a sudden you're telling me something. So I think there's going to need to be a non-digital, hands-on approach in the community, partnering with community organizations, but bringing this level of data analysis efficacy there, which actually is probably more valuable there than even some of the big institutions. And so there will need to be a hands-on part to how we start to get this adopted. And once we gain that trust, I think then you can say, okay, we're doing large swaths and populations. I think the second part is for any clinicians out there who aren't early adopters, and many of my friends are not, so I'm speaking to them. We recognize what we're saying about the large amounts of data and the idea of a digital biomarker on top of their regular biomarkers, on top of their social determinants of health. It is a lot of data. And so I think one thing we have to claim that we are responsible for, along with any other organizations, industry that is helping us do it, is creating models that then have a really beautiful and accessible user interface that isn't one out of 15 things that people need to use. And so we hear you and we know that, and we're not suggesting that we will give you 27 different, windows to open. I would love to hear from the others, though, of how are we actually going to get there, right? Because there are a lot of people in this field. There are a lot of companies in this field. There's room for everybody. There's not going to be one model globally, right? But how do we get to a place where we really create a user interface that has the right data for the right patient at the right time? How far? I think we're a little far away from that, but I don't know that we've clearly defined the steps. And I feel like this group might be one to start laying those out as a conversation.
So, I think you make such a great point here, like work-stream integration is what you're talking about, and trust and awareness, right? And I'm just going to point to a HIMSS study that was done last year just to kind of see where clinicians were at in terms of acceptance. And in fact, they found over 50% of clinicians are very interested in remote monitoring. And in fact, we just did a survey, which hasn't been released yet, but I can talk about the preliminary results over at Medscape. Same kind of findings. The audience is primed and ready. But back to the HIMSS survey, the two issues, to your point, Ami, were basically technical interface and technical competencies of understanding, the wearables or how to download the data, how to get the data, as well as privacy issues. So we'll go back to the privacy issues in a second. But let's talk about what you just brought up. Who would like to jump in?
I can probably that a little bit. I mean, so it's a really interesting point. There's a couple of things to unpack there. One is, I guess, the concept of an integration platform that presents multiple streams of data in one interface is really important, right? Because you have lots of different types of wearable that are defined for different types of condition or monitor different parameters. And they'll be made by different manufacturers. And what you don't want to end up with is multiple different backends in a central monitoring unit or a clinic or wherever these people are consuming the data, where I've got to look at this screen for that piece of data and that screen for that piece of data. And then I've got to try and work out what's going on with the patient. So we need an integration platform. We need one front end. I think it also ties in with the concept of shared care records, which certainly is a big topic over here in the UK at the minute, because we're blurring the lines between primary care, social care, secondary care, acute care by expanding what we're doing and making it less geographically confined. So we need to understand who's going to consume the data and where are the data living and who can access them, because these patients, the people that we're looking after, are going to cross those different silos, and we don't want the data to be siloed at the same time. My final point would be, there's a concept of running before walking. We have to understand what patients we're looking after. What are we looking for in the patients? Because if we're going to remotely monitor patients, it needs to be patients that we can intervene with early enough if the thing that we're looking for happens. So there's very, very little point in remotely monitoring a patient for sepsis or for a GI bleed. Even if we think it's a remote chance that this is going to happen with the patient, if we can't intervene immediately that we see the markers is, we're going to have problems with the patient. So it's kind of like having a traffic camera on a major junction, but no traffic lights. You're going to see a lot of accidents, but you're not going to prevent any, right? So we have to monitor the patients who are at risk of a deterioration and would need a clinical intervention, but where the deterioration is signposted well enough that we can intervene early and we have proactive care and we manage that patient, if that makes sense.
Maybe I could chime in this. What Ami, the question that Ami asked is really important, because this is a question that almost every doctor that I've spoken with has. How do we do this? I don't want to have more data. How do I do to actually have the right information, but not everything else? And so I've been working with different hospitals for some time now. One of the projects that I'm working with is with a company in Finland and Oxford University. And they are trying to create a remote monitoring program in which they remote monitor all the patients that get out of the coronary area after they've had a procedure, and then they go back home and they have to be monitored along a period of time. And there's an amount of parameters that they want to see. And then I work with another hospital in South America, and they are actually monitoring patients in the emergency care and in the cardiology departments, and they want to do different types of monitoring techniques and different vital signs they want to see according to the location of the patient and let's say the disease, the severity, the pathophysiology. Like, there's a lot of different endpoints that eventually kind of like decide which vital signs or which parameters they have to be monitored, and or the combination of both of those in terms of like risk scores, etc. And what I learned from this is that you need to have a strategic person or let's say a strategist in the hospital that understands a little bit of the technologies and a little bit of the pathophysiology or medicine itself, to be able to decide what will be seen by whom and when in terms of remote monitoring, because we cannot just give every hospital the same tool. There's a lot of hospitals, for instance, in South America, that in the times of summer, the majority of patients that come to the ER are patients that are dehydrated because of, endemic diseases that are basically originating into gastroenteritis, etc. Or there's dengue in the Amazon jungle, or there's Lyme disease in Europe, and there's a lot of different epidemiological factors in terms of what we have to monitor when we talk about vital signs, etc. So, I think that a strategic point of view of remote monitoring, what, by whom, and how, are things that have to be decided by hospitals before they arrange remote monitoring technologies inside of their wards. Otherwise, indeed, they will burden the doctors. But the other outcome is not burdening the doctors and actually giving them tools that they didn't think they had before, where they will be so in contact with the patients that they will be able to prevent and also to treat on time exacerbations, complications. So this outcome can be actually decided by the strategic point of view of the hospital itself.
That's a great point. Sandeep, do you have any thoughts on this as a serial entrepreneur who's probably dealt with hospital systems? I mean, how do you actually penetrate the hospital system? And, is there a role for a chief innovation officer or chief digital officer who can actually oversee this?
Yeah, it's a moving target, right? Everything is always in flux, and hospitals are moving in this world right now in between, right? Shifting from traditional fee-for-service in the US model, from fee-for-service to these value-based programs. So it's important that your technology stack, if you will, starts with, what is central to that, right? If it's obviously the needs of the patient, the needs of the providers, the needs of the payers, all have to align when you build these programs. And wearables and the data itself, sort of have to disappear. Where you're really providing is insights from that, right? Where is the value? You have to engage patients, yes, to collect that. But then when you are trying to operationalize these, it's like I said before, it's shifting from basic monitoring now to management. How do I make use of this data so it helps to operationalize this in a way that's efficient for my health system, to interact with patients at the appropriate time, and also start segmenting the right level of care that is needed for that action that needs to take place for what that data is telling you, right? So it's like stratifying the actions that need to be performed. For example, when you start with a really complex use case, but can then be broken down into simple actions that can be informed. Like, for example, one of the things that we're able to do on our platform now is helping to automate treatment for CHF patients, right? Which is only 1% of heart failure patients are on the optimal therapy, the dose and the type of medication. When you looked at that problem, it's looking at not just the collection of information from the patient's perspective, but then how do we take that information and add value and increase access to that level of care by using all the systems that we're talking about today, right? Collecting the data, streamlining the access to the information coming from that data, and then making sure that the clinicians, not just the doctors, the nurses, the entire care team is inserted at the appropriate level to meet the needs of that patient, so that the patient is obviously getting the best outcome. So I think that's really where things are moving, is making that information into the workflow, but also informing the clinical decision that needs to take place so that it's improving the outcome for that patient.
Absolutely. Ian, Ami, thoughts? And
Ami, you go.
Yeah. No, it's such a good conversation. I guess part of my thoughts, since we do have all of us here, is are there differences in how we're going to do this globally? Because we're unique in that at least we're all here together, right? Because here in the US, we face certain forces that are external forces, if you will, that really shape how the healthcare system functions. Capitalism lying at the bottom of all of that, but also, some of our issues with the diversity that we do have in this country, and then our inability to traverse some of those chasms in our attempt to close the digital divide. I'm just curious, kind of in the global or in the European market, and I don't know if anybody here can speak to the Latin American market as well. Are there unique challenges there that you guys see that we're not seeing? Because it seems silly for us to start creating solutions that are country specific when maybe we can start to create things that are a little bit more portable, recognizing everything has to be personalized at some point. But just to make sure that we're not missing things, I think this is a unique opportunity for us to think a little bit about that global lens. So I guess I'm kicking it back over to you guys.
Yeah, I mean, I think the one thing is, I'm sorry, I'm just going to insert this comment. I think the one thing that is global, I would think, and I would love your opinion, that we could work together on, is something that someone mentioned, and that is like buy-in, right? Like clinician buy-in, right? Trust, and how, like, that's something, unless the Latin America or Europe or other countries differ in that, I think clinicians are very much the same in terms of being primed for more information on this, but still wondering about trust and workstream integration and all of that. So is that something that we can tackle from a global perspective in terms of, how do we do that?
Yeah, so there's a phrase, and some of you might have heard me say this before, but have been having some trouble with getting people to buy into a variety of things, right? For telemedicine, I did it for 7 years. I asked friends to join me. Maybe in a snowstorm, one person was like, "I'll do this in Boston," but doing something new is hard. Partly it's hard because we don't have the system. So again, the infrastructure and the workflow, making it easy, making the outputs easy, true. But the second is you have to understand what's happening. And so artificial, the word artifice means deceit. That's it's going to have old Middle English origin. And so the idea that we're telling people that we're going to give you something that's going to deceive you. And so we've changed that terminology at ACC Innovation to collaborative intelligence, which is putting a little bit of that responsibility back to the clinician saying, what is the data that you're trying to work with, right? We're going to put it into the analytics and then you're going to get an output. And then that output is either going to be spot on, which is great. It's going to show you new things, which is discovery, right? And clinicians like discovery, And then the third thing is it might be wrong. And I think that's the part where we can message the most clearly. If we are looking at our data using analytics and we get something wrong, whether that's from remote monitoring, whether that's from the EHR, that doesn't mean that that technology failed. It means that it's our responsibility to go back and iterate on that. And I think that concept is one that if we can start getting people used to, then the trust starts to come because you see that no one's trying to shove something at you, but we're trying to help you create the right analytics for yourself. And so, I think that's a really important message that we can give.
I completely agree with you, Ami. I like this part when you say iteration. I think that if you think about in hypertension, how long does it take for a patient to go from diagnostics to maintenance therapeutics? It takes them a long time, especially because we are used to the typical intermittent monitoring, right? You go to the clinic and then you go back home, and then we try it for some time, then you go back see your doctor. We check some logs and we continue like this, and it takes them for a long time. If we can use remote monitoring, then actually we can shorten that time, and we can show the patient about this iteration that you say, we're gonna use this, we're gonna use that, because I see the trend of your results and it's not working that well. So let's just continue. They see that we are basing our decision in the data, and at the same time, they understand a little bit better why we're doing things. As doctors, we can show them with graphics, with information, what is our train of thought, and bring them with us in the journey of this disease, and how we can actually be a team, tackling the disease. So I think in general, what you said, iteration, that's something that is a concept that I would love to be able to propose at different hospital levels in where I work with. And when you ask about the global challenges, I think that one of the most global challenges, or most important global challenges that I see, is equity. Because when we talk about Latin America, if we are going to be remote monitoring the patients that have insurance or that are being seen in the private care, we are not really going to be let's say winning against chronic disease, because unfortunately the populations that are the poorest are the ones that usually have the biggest amounts of diseases that actually have to be monitored. So it becomes a public health problem. And I think it's the same in the United States, if I'm not wrong, probably in some countries in Asia as well. I think in Europe, they got it figured a little bit in some of the countries here. Also, I think that the trust in the doctor, it's not something that here in Europe we see as a very, very big issue. I don't know about the UK, because you guys have a different culture in that way. But at least in the Netherlands, Germany, Belgium, we don't see this being a really big issue, trusting your physician, as much as I think being not really adapted to or not having enough digital literacy, and therefore not wanting to cooperate because of the inadequate digital literacy. So that's also something that we have to tackle.
I do agree with you, Jhonatan. Such a great point about equity, right? And access. So and that I worry about that actually, right? Like, we don't want to broaden the digital divide, right? So again, widen the gap between the haves and have-nots. Sandeep, Ian, do you have any thoughts on that?
Yeah, I mean, I can just add a quick couple sentences, right? So you have to understand the patient populations and how you build these programs, right? So sometimes it could be as simple as someone downloading an app, but that may not work for everybody who doesn't have the right data plan or even access to broadband. So you have to construct these programs on first solving that primary question of how are we getting this information from the patients. And I'm sure Ian has a lot of experience in this in terms of integrating these tools together. So you have to tailor these programs to associate with the type of needs that are in those populations, like language barriers, access to making sure that ASL patients are included. So there's a lot of components to building these programs from the ground up. So solving the access issue is primarily universal, right? So it doesn't matter where you are in the world. And I think those challenges are going to be solved in the near future, where access to pretty much broadband globally is going to be hopefully coming soon. But once today, right, you have to understand those patient populations, segmenting how you collect that data is really important. And, you can't obviously start with a broad approach. You have to start where you have when you're building sustainable programs where it can show value and then expanding. So unfortunately, it is a big issue because you can't deliver care almost globally, but you have to start working on populations that have the biggest need and then focusing on how to solve those access challenges and then going up to helping what Jhonatan was addressing, which is having doctors and clinicians understand how to use these digital tools. But in terms of access, you have to construct these programs to address the needs of your patient population. Ian, I'm sure you got a lot to add there.
Yeah, I will condense it real small, I think. But yeah, just to the point of addressing it globally. Yeah, sure. Health systems are different around the world. The UK system is somewhat unique with the NHS, very, very different to the US system, different to some systems in Europe. So the way health is delivered is a bit different, but I think there are certain truths which are universal, which is preventative care is better than responsive or reactive care. It's cheaper and it's more effective. Continuous monitoring is better than sporadic monitoring. You will pick up deterioration much more quickly, and your intervention can be more successful and again, more preventative. So I think it becomes less of an issue around how health is delivered in a country, what that country's health system looks like, and more, I think, to Sandeep's point, it's an infrastructure issue. If we're going to start doing this stuff outside of hospitals, outside of clinics, it's how do we get the data to people? And it's about, the projects that I've been involved in where we've done remote patient monitoring in the communities, we send district nurses out with kits, right? Wearable kits with a gateway device that does the data transfer that belongs to that kit. And then it all goes back to the right place. And that's the issue that we need to tackle globally to bring Jhonathan's point of equity, right? But I think the health challenges, they're pretty much universal. You can transpose those anywhere.
Absolutely. Great points, Ian. Well, unfortunately, this is such a great discussion, but we are coming to the end here, and I'd like to go around the table before with some final closing remarks about just a general question of, how do we ensure equity for the wearables, and also let's not underrate the impact that this data is going to have on healthcare. So on either of those topics, if you could just give us some closing remarks. We'll start with you, Ami.
Well, thank you. This has been a great conversation. We can always go on for a long time with this group. I'll take the equity piece. I think when we're addressing equity, although there are specifics to whether you're talking rural America, inner city Mexico, anywhere in India in general, right, where we're having challenges getting access to care, we need to pair those efforts with clinicians as well as local community or government, depending on where you are, and then a combination of health and digital literacy and trust. I think that's almost like, it's like a little, that's a unit, right? And that unit kind of changes over time. I don't think we can do that alone. So I think there are a lot of organizations doing good health digital literacy work, but maybe don't have the clinical workflow or the people they're invested to be able to make that happen. I think there are those who are trying to, like we talked about before, put digital health in there and put wearables in there, but don't have that other element. And you need community buy-in And sometimes you really need government buy-in globally. And so I think that triangle is one that people aren't drawing a lot. We're talking about crossing silos a lot of other places. Let's have VC and startups work with academia. You know, we hear those conversations a lot, but what we're not hearing is we need community government, we need health digital literacy, which will engender trust if we do it right. And then we need those clinicians. And I would love to see people using that triangle more and trying to figure out how do we do that. I think that will help us achieve equity.
That's a great point. I mean, I think you're going back to what we've had in the United States, and that is a miscommunication crisis, lack of trust, awareness. There's so many levels, but grassroots are really important to kind of combat those issues. And we certainly don't want to go down that spiral that we've seen with vaccines and other public health measures in this regard. So absolutely. Sandeep?
Yeah, no, thanks again. It's been a great conversation. And I think, Hansa, you know this from where you are in your organization, right? Helping build trust around these new applications and tools is going to be a big issue, right? Even though we've been now doing this for 10 years and COVID did accelerate the learnings, both good and bad in terms of feasibility and what could be done with patients when they're not in front of you. There's still a lot of work that needs to be done in, helping to ensure that these type of tools can inform and help address areas of access that can't be delivered today, right? As more of this care is shifting out of the hospitals more into the home setting, it's going to become important to understand what tools can be trusted, how you use this new kind of delivery mechanism with your current training. And I think it's a lot, for us, it's going to rely on helping helping educate our provider networks and teams to how to utilize this new kind of models. And I think, education is going to be key to that.
Absolutely. Ian.
Again, like everybody else, thank you so much for the conversation. It's really interesting. I guess from my point to finish with, I would suggest, as I said earlier, maybe try and walk before you can run. So it's about, I think, taking this journey in steps and in phases rather than trying to leap it all in one go. So there are areas where improvements can be made very, very quickly without massively impacting the operational readiness of the healthcare system. So doing more continuous monitoring on general wards in hospitals or post-surgical patients in hospitals rather than out of hospitals, but using wearable remote monitoring to give continuous visibility of those patients rather than the sporadic checks that we do at the moment. That will help reduce the burden in those environments already, and it will increase the good outcomes for patients. And then you can start to kind of expand this out to specialist clinics where we know that we can monitor patients outside of the hospital and go further and further until we get to the whole population health management piece, where we would be using artificial intelligence or collaborative intelligence, as Ami put it. I think we've got to take it in steps. We've got to do things like clinical decision support before AI, right? Those aren't the same things, but it's take steps, get used to the technology, reap the benefits at the early phases, and use those to invest in the right kind of workforces to support the more nebulous piece of monitoring long periods of time, large groups of patients in non-geographically confined areas, because that is going to be more of a challenge. And I think you need to set up a big workforce behind that first.
Absolutely. And Jhonatan, great points made here.
Thank you. Well, thank you all for being here today. It was an amazing conversation. I would like to end up with a thought. I think that we have to choose the right pilots. If we really want to create this adoption to remote patient monitoring, we have to choose the right pilots. I see a lot of different hospitals creating or asking for remote monitoring without really knowing how to apply it or how to implement it or where, for who. And there can be a lot of outcomes from remote monitoring. You can say that you could have amazing health economic outcomes for a hospital combined with incredible outcomes for patients. And at the other hand, you can also have incredible loss and none really having results that don't really signify much efficiency in the hospital. So, and that all can come from the same type of technologies, just applied to different types of patients and in different types of departments with different types of purposes. So I think that when you want to integrate remote monitoring in your medical system or hospital, make sure that you have someone that writes an amazing pilot that has all these things in mind. You know, who are your patients? What's the pathophysiology? Which disease? Why are we doing this medically? Why are we doing this economically? What are our desired health economic outcomes? And when you have all these universe of questions responded, then your pilot will succeed, and your doctors will adopt, and your patients will be, seeing the results of this program, which is prevention, early detection, early detection of complication and early treatment. And they will be also very grateful. And this is how these types of remote monitoring projects end up succeeding. I have seen a couple of really great examples from the Netherlands. I have also seen a couple of examples that are not that great. And that, in my opinion, it was all about how the pilot was created in the first place.
Great points, Jhonatan. And I, too, just wanted to thank the panel. I mean, it seems like we're all on the same page. We do have a lot of work to do in those areas. But of course, we all realize the incredible impact that digital wearables and remote monitoring can have on healthcare. So exciting times for sure. Absolutely love talking to you all. Sure, we could talk for another 3 hours, but unfortunately we have to close here. So thank you for being here, and look forward to the next discussion.
Thank you so much.
Thanks, Hansa. Thank you.
Thanks for having us.